for me personally, it's very heartwarming to be here. So just a few points. I think I'll make 4 points. So the first point I wanted to make is that we have 1 out of 5 people in conflict situations experience some kind of mental health issue. Obviously, there are groups within that are more vulnerable, but this really does highlight that it's a huge cause of concern and something that, you know, we are all collectively engaged in and working to address. So that's the first point. I think the second point is that obviously I've mentioned the work that has been done in recent months and years, and there has been progress. So if you recall, during COVID, the Secretary General published a policy brief to draw attention to the issue of mental health. And there was also a joint interagency call for action in December 2020 that was endorsed by IASC principals as well. So those were 2 very important things. And then, of course, in emergency settings, we now have the guidelines on mental health and psychosocial support that are IASC guidelines. So this is sort of some of the progress, if you like, some of the highlights that have been accomplished in recent months and years. But of course, there's still a lot of progress that can be made. And I think, you know, this is one of the reasons that it's wonderful to have all of you here today, and of course, our online colleagues. I also wanted to say that the MHPSS Reference Group exists as part of the Interagency Standing Committee. So the Interagency Standing Committee, as you may or may not know, is the global humanitarian coordination forum that is chaired by Martin Griffiths as Emergency Relief Coordinator. And there are a number of structures within the IASC, but essentially everything rests on the shoulders of the principals of the 19 members of the Interagency Standing Committee. But within that, we also have different groups that work on very specific areas of work. And so we have the Mental Health and Psychosocial Support Reference Group that actually reports into the Operational Policy and Advocacy Group. That's a lot of acronyms and what have you. But the point is that mental health and psychosocial support is embedded in the IASC structures, and we're delighted to have it embedded in the structures and be able to, you know, support in the important work that has been that's been going on. We have been, you know, blessed with the leadership of Carmen, IFRC, and FAMI with the World Health Organization. And really, it's sort of incredible to me how, you know, we look at so many issues in the IASC, but I think the grassroots angle of this work has been pivotal to really garnering action. Often we see things generated from the global level down, and I think in this case, it's really a lot has happened in the opposite way, and I think that's been very, very positive. And then finally, I think that we do have a lot to do on mental health. You know, we work in emergency settings and we provide food when people are hungry, we provide medicine when people are sick, but obviously mental health is a much more sort of complex, nuanced issue. So we do need to move away from this notion that MHPSS needs could be met just through the health system or just through specialized NGOs, and that we all have a collective responsibility to understand and be able to address mental health concerns in the field. So thank you very much, colleagues, for being here. Thank you for engaging. This is all about, you know, networks. It is the Partnership Network Week. So I would encourage you to, you know, use this opportunity to really sort of raise the voice of the important work that is being done by the community. Thank you.
Thank you so much, Sam, and thank you for the support from the Interagency Standing Committee. It's such a privilege for us to have that big IASC logo behind us, just bringing, as we will comment in a minute, bringing the work to country level and allowing our colleagues at country level to unify voices under this big umbrella and strong joint community. So we really appreciate. Stay with us if you have the opportunity. We know you're busy and you might need to leave us at some point, but please stay with us as much as you can, and thank you. And to the colleagues joining us online, we have now a bit more of 60 participants, and to all of you in the room, just to let you know that we're going to have two stages from this point. First, Fahmi and I, we work together. We're both the co-chairs of the reference group, WHO on the side of Fahmi, and myself, IFRC. And we would like just to maybe let you know a little bit more, what is it that the reference group does, what is our daily work. And afterwards, we have a panel of some of our partners and organizations that are members of the reference group to build a little bit more on what that looks like. And there will be opportunity for questions. We would really like to hear questions, and especially, as Samantha was saying, in a week of partnerships and networks, the core of this session is to really bring close to you, how can we engage better? How can you get in contact with us? So please feel free to join us with your questions. Also online colleagues, we have a couple of colleagues joining us, Maya here in the room and Barbara online, to monitor your questions and make sure that we can answer to as many as possible. So Fahmi, welcome.
Thank you, Carmen, and hi everyone. It's a pleasure to be here today. I think if the humanitarian system did not have an IASC MHPSS reference group, somebody would likely have invented it. Humans do not survive in emergencies, or do not cope in emergencies, or do not recover after emergencies with water, food, and shelter only. That's what make a huge difference about being human. The idea came after the tsunami about the need on bringing one consensus-based document, which is the IASC Mental Health and Psychosocial Support Guidelines, where the work started back in 2005, completed in 2007, and then was the birth of the IASC MHPSS Reference Group as part of the IASC system, as part of the humanitarian system formally. The idea was to develop a group not under health or protection or nutrition or shelter, a group which is cross-cutting, that is now composed of 63 organizations representing UN agencies, international NGOs, Red Cross and Red Crescent movement. Functions of this group is including development of consensus-based documents such as the IASC guidelines and many of the products we are going to share with you today in this session, mainstreaming mental health and psychosocial support in clusters and in other humanitarian entities and bodies. Finally, a very important function, which is supporting country-level coordination of mental health and psychosocial support through existing technical working group and establishing new ones with acute emergencies. And what we saw during COVID-19 is a huge growth. I remember the first time MHPSS was represented here in HNPW, we were putting in our slides back in February. It was Peter and I, my colleague from UNHCR. We put in the presentation at that time, 23 countries in the world in emergencies having mental health and psychosocial support coordination. Today, we have 59 countries. Almost every country which have a humanitarian migrant response or a refugee response have a mental health and psychosocial support coordination. That brings lots of demands on a body like IASC MHPSS reference group and require focusing on quality. Isn't it, Carmen?
Yeah, absolutely. And I think that grows from, that growth that you were mentioning from 20 to almost 60 at the moment, it comes with even more pressure on our side to secure quality, to make sure that the main role of the reference group, which is carrying those guidelines from 2007 to everywhere where a new country, where a new group is established, I think is really important to us. Those guidelines were not a description step by step on how every organization has to do MHPSS in a country. Everybody has to do the same. Each organization has their own protocols, their own different ways of contributing to the biggest spectrum of MHPSS response. But there has to be some core principles. There has to be a standard. There has to be a quality that we feel very strongly is a big part of what we need to do. And through those tools, those functions that we cover, I feel very strongly that one of our main roles is to secure that quality, especially in a moment like right now when we see even more and more and more interest in MHPSS. We are really thrilled that this is happening, that so many organizations are now also joining the MHPSS activities. Now more than ever, we have to be careful that we don't lose that quality, that we keep on using the higher standards in our work. And that is a big part that I feel of what we need to do. And that relies very strongly on those technical working groups we were mentioning. I'm not sure though, we use a lot this technical working groups word. I'm not sure everybody will be familiar about. So maybe Fami, if you can share a bit, what is it that is a technical working group?
Yeah, I'll explain a bit of the rationale. Why do we have mental health and psychosocial support technical working groups? This area of work in countries in humanitarian response have services scattered across all clusters and sectors. For example, in good humanitarian practice in the education sector, you might find a colleague working on mental health and psychosocial support and education, doing mainstreaming of mental health and psychosocial support in school, as part of school mental health promotions or life skills training. In good humanitarian practice, you may find a colleague working, for example, with UNFPA, working on integration of mental health and psychosocial support for gender-based violence survivors as one of the integral and key pillars. In good humanitarian practice, you may find someone working with Save the Children, integrating mental health and psychosocial support aspects into child-friendly spaces. You may find someone working with the health sector, integrating mental health into primary health care. These are different sectors and clusters. If you are familiar with the cluster system of humanitarian emergencies, we need a space where these focal points who are working in different sectors and clusters doing this good practice come together to ensure there's no duplication, to ensure there is a referral mechanism, to ensure there is synergism, to ensure that they are aligned with good humanitarian principles as the IASC guidelines. That's why we have mental health and psychosocial support technical working group. You cannot really coordinate mental health and psychosocial support, then provide good quality services, which is interlinked, integrated, unless you have mental health and psychosocial support technical working group, not under one sector, not under one cluster. There is a misconception this should be under protection or under hedge. These are cross-cutting groups. If you are familiar also with humanitarian structures, it's more like cash groups. They are cross-cutting groups. And we support these groups with many ways. We do surge support, rapid deployment mechanism, like the very good mechanism now. Sandra will share with us from the Dutch surge support. And that led actually to growth of these groups. And we support them by missions that Carmen and I do. And there are other ways we also support these groups with Carmen.
Yeah, absolutely. And I think that support is, for me, it's a really beautiful way of working because we kind of support each other. We have this continuous source of engagement with them. I would like to highlight what Sam was also mentioning about this grassroots nature of the reference group. We don't just decide ourselves, let's do a guideline on this. We listen to the ground, we listen to these groups. They tell us we don't have enough, we don't know what to do in terms of suicide prevention, or we need more strengthen ourselves in monitoring and evaluation. Then we come together and we create resources. And I think having that information from them is amazing, is why we create guidelines that are very, very used. And then we can support them in making sure that those guidelines are well used at country level, that they have the capacity, the training opportunities, etc., to provide those guidelines at country level. So training is essential for us, capacity strengthening of the groups and of the coordinations of the groups. We are in pretty much daily contact with all of these coordinators in so many contexts. We share information and technical advice with them on a daily basis. And we also provide something very important, an opportunity for them to come together, to talk to each other, to share lessons learned and ways of working in each of the contexts, which brings an incredible opportunity to a colleague in another country to also learn, they're doing it that way, we're doing it this way. So these exchange opportunities are also very important. So that big capacity strengthening element, I think is quite key from us to them.
Thanks, Carmen. I learned from our good colleagues at the IASC Secretariat that around half of the traffic coming to the website of IASC is coming to look into mental health and psychosocial support resources. This is collective work of the 63 agencies who are members of the IASC MHPSS Reference Group and the dedicated work of our good colleagues at the IASC Secretariat in making these resources available for the humanitarian community. But what are these resources? There are resources which would tell you what to do and how much it costs. My colleague Inka from WHO will present about one of these resources, what to do and how much it costs, a minimum service package for mental health and psychosocial support in emergencies. Very helpful tool, looking into various sectors, what you really need to integrate as services into each sector. But it tells you what to do, but it also gives you links to all the resources on how to do it. So for example, if you want to know this concept of mental health and psychosocial support coordination, practical tips, examples of good practices from countries, there is a handbook for mental health and psychosocial support coordination available in multiple languages. If you are working in WASH sector or shelter, food distribution, and you want to make sure that you integrate a set of basic psychosocial skills in your daily work, there is a tool helping you how to do it, basic psychosocial skills integration. You'll see various humanitarian workers, including law enforcement, including health worker, protection actors. This is a set of basic skills that this tool would tell you how to integrate. A recent tool also was developed addressing a blind spot in humanitarian response. How can we address self-harm and suicide that nobody is speaking about in camps or in urban settings? So there was a recent IASC tools telling us how to address suicide and self-harm. And I'm coming also to an interesting tool we developed during COVID-19 among many. And we were so proud that this group actually developed the resource, which was one of the most translated books ever. I think it ranked 8th or 9th most translated book, a simple storybook that is printed and disseminated online, became one of the most translated books. It helps the children to cope with stressors related to COVID-19 and available in 145 language and 45 plus accessible formats. So these resources are available online, but what's important is how these resources are getting used.
Yeah, absolutely. And how we see that traffic, that the downloading and using of the resources, and how much positive feedback we get from them, and that encourages to create more resources and to keep on engaging the organizations that are behind this work. I think it's very important to say that when we say the reference group, Fami and I are sitting here because we lead the work, but that work is all of the amazing organizations that are MHPSS, active organizations that are coming together to do these resources. Our colleague is sharing the links online. We will have a couple of QR codes at the end of the session as well, but we also have a booth this week here. So if you want to come and say hello to the reference group, we have a booth as you enter to the right. We are there, and we'll be happy to share more and to see what you think about them as well. And we really wanted to hear our colleagues from the ground today. Yeah. We would have liked to invite all of them here, but instead of that, we had a different way of listening to them.
Yeah, it was important to listen, colleagues. We don't develop these resources to be used in Geneva or in New York or London. These are resources for colleagues who need them at the front line in countries implementing mental health and psychosocial support programs. So we are grateful to Maya, who compiled a number of videos from colleagues who lead mental health and psychosocial support coordination in complex emergencies. And we're going to learn from them how they use this tool and interact with this global structure.
MHPSS Technical Working Group in Ukraine brings together almost 300 partners. Coordinating so many partners is both an achievement and a challenge, especially in the situation of the protracted conflict, which escalated into a full-scale invasion of Ukraine by the Russian Federation in February 2022, and combined with a health emergency such as COVID-19 pandemic. In a country where emergency affects almost 42 million people, coordination of partners' efforts becomes more important than ever. We established a network of regional level groups to strengthen MHPSS response and coordination at a local level. The MHPSS Technical Working Group in Ukraine works in close cooperation with health, education, and protection clusters, gender-based violence, and child protection subclusters. Partners contribute to the implementation of the all-Ukrainian mental health program launched by the First Lady of Ukraine, Olena Zelenska, and support health, social, education, and other sectors in building capacity of their staff in MHPSS.
The Mental Health and Psychosocial Support Technical Working Group in Syria plays a critical role in the timely response to the complex emergencies that we witness in Syria since more than 10 years, and which topped up lately by the sad and tragic incident of the Turkey and Syria earthquake in February. The main role of the Technical Working Group is facilitating coordination and collaboration among different actors involved in MHPSS interventions in Syria. As a justified fact, we believe that coordination is a life-saving approach that enables the efficient and effective use of resources and ensure that MHPSS interventions are evidence-based, culturally appropriate, and responsive to the needs of the affected populations in Syria. The Technical Working Group serves as a platform for sharing information, best practices, and lessons learned, and also for advocating for the integration of MHPSS interventions into broader humanitarian response, which still considered as a challenge that we face and that we try to bypass through the coordination effort. By working together and sharing knowledge, the Technical Working Group can help to build capacity and strengthen the quality and effectiveness of MHPSS intervention in emergency settings that we still witness in Syria and build back better the MHPSS services.
Yo soy Clara Astorga, soy psicóloga y trabajadora social. En este momento estoy contratada por la OPS como especialista en salud mental y estoy actuando como coordinadora del Grupo Técnico de Trabajo SMAX aquí en Venezuela. El Grupo Técnico de Trabajo SMAX es fundamental sobre todo porque nos permite conocer cuáles son los recursos y las iniciativas que muchas veces inician trabajando las organizaciones o las comunidades que se organizan para poder dar respuesta a una necesidad. Y ahora, estando un grupo técnico de trabajo, nos permite entonces identificar dónde estarían las brechas, porque efectivamente al salir de forma natural, un poco sin tener claridad de lo que son las necesidades nacionales, pueden estar repitiéndose iniciativas en algunos sectores, en unas áreas, y podrían haber vacíos en otros sectores, en otras áreas, sobre todo desde la perspectiva de la pirámide. Entonces el grupo técnico de trabajo permite conocer cuáles son las iniciativas, ver dónde siente la población y los actores humanitarios que hay más necesidad, permite que haya una construcción de saberes, porque cada vez que los actores se encuentran, comparten sus perspectivas, sus experiencias y sale distinta la respuesta, sale mejorada. Permite además visibilizar la acción humanitaria como un conjunto y eso creo que nos va a hacer más visibles.
Poland MHPSS Technical Working Group has been created in March 2022. Through all this year, we had over 100 active participants. We created a Google Drive, which held all the essential and important information available for partners. Also, this is a platform for direct communication and exchange of information. With the support of our partners, we created a strong service mapping for Poland, including national and international partners. We proudly held a workshop in the field of level, also created capacity building events and trainings for all partners around the country. With the support of our partners, WHO and other organizations, we translated IASC materials, including IASC guidelines and other essential information. We're constantly working on dissemination information and plan to hold an event for dissemination of useful information. We have managed to build a strong linkage between health, MHPSS, protection, child protection, and GBV sectors. We constantly exchange of information and updates.
In addition to what Olga has stated, we would like to highlight one area that has been a challenge for many actors in different sectors: suicide prevention and response. Last year, we have focused our efforts into suicide prevention. But this year, as co-chairs, we have designed a series of workshops that are tailored for suicide response. But just like any context, Poland is not without its challenges. And the biggest challenge we have faced through the year was engagement of partners in service mapping. And how we ended up overcoming this is by engaging especially national partners on the ground level, in the field, in different areas. And this became a testament to the strength and collaboration in this working group.
I love our colleagues so much. I just see them in the camera and I'm like, hi. They are fantastic. And we are really grateful that they took a little bit of time in their busy schedules to send us a little message. This is actually, yeah, you can go back 1 second, Barbara. Yeah, this is the technical working groups that are active right now globally. And just to bring the attention to that, about around 60%, because we'll go back to this reality, which is that around 60% of the technical working groups are co-led in one way or another by local organizations, local governments, so on. So that localization agenda is something that we're also trying to work on through the coordination at country level. So we hope this has shown a little bit what is it that we're doing in the reference group, but to go a little bit more in detail on what we're doing on MHPSS and what our partners are doing, we would like to invite to join us up here to our wonderful panelists today. They're scattered, so now the audience gets even a bit smaller, but that is fantastic. So I would like to introduce you all to Peter Ventevogel from the UNHCR, Victor Hugo from the MHPSS Collaborative. We have Inka Weisbaker from WHO, and we have Sandra Katz from RVO joining us here. Thank you.
Thanks, Carmen. We are grateful for our colleagues, technical working group leads. If they don't exist in the field, services would be seriously fragmented. A child who have a mental health condition and is at school and is exposed to domestic violence cannot be divided, and we tell them your mental health services would be fragmented. You need a mechanism linking services that they would need in education at school, linking services that they would need at the health sector, and linking mental health services that they would need, which would be at protection together in technical working group. But we are talking a lot about services, Inka, and it's really important in the field of mental health and psychosocial support to have a minimum standard package, so that donors also can have expectations, how much it costs. Can you tell us how this package was developed and how it can be used, and if help is available?
Yes, thank you, Fahmi. So the mental health and psychosocial support minimum service package, it's quite a long phrase, so we often just say MSP for short, was developed with support from the Netherlands over a 3-year period with participation at the global, regional, and country level of many different humanitarian actors and stakeholders. And now, as of a few months ago, has been published as an IASC document, which we're very happy about. So the MSP really lists the most important priority activities that should be implemented in any humanitarian setting. That, of course, includes coordination, as was already mentioned. MHPSS technical working groups are very instrumental, but also given that MHPSS is really cross-sectoral, the collaboration across different sectors, such as health, protection, education, even shelter, CCCM, WASH, nutrition, all of them have a role to play. So the MSP really helps different sectors and AORs understand where do they fit in the MHPSS response and which activities they may be best placed to implement or to contribute to. So the MSP can be used really by anyone. You can go to the MSP website or just Google MHPSS MSP and you will find it easily, although QR code is provided as well. And you can see a list of the different activities. For example, development of key MHPSS messages to promote positive mental health and coping is one activity. So you could click on that activity. You will see an introduction of why this activity is important. Then you will see a list of actions that should be implemented to complete this activity. For example, consultations with local stakeholders, local populations to make sure the messages are appropriate and easily understood, for example. Then often you have some key considerations to know when you implement the activity. You see different sectors or AORs who can contribute to this activity. For key messages, it's actually quite a lot. Even, for example, if nutrition does not develop the key messages, they could still distribute them. So that really shows how different sectors can collaborate on the same activity. And at the end, it also gives you a list of guidance and resources to implement the activity. Almost every month, new guidance and documents and tools are coming out in MHPSS that are also sent through the IASC MHPSS Reference Group mail out. And the MSP online website really provides one place that you can go and find all these resources in one place. So for example, for dissemination of messages, you go to relevant guidelines and tools, you click on that, and you see all the different guidance that has been developed on this, and also some example key messages. So this is how the MSP can be used by implementers. Of course, the MSP can also be used by donors as they're reviewing proposals, for example. Donors don't always have extensive technical expertise on MHPSS. They have to cover many different sectors and areas. So the MSP is an easy place for them to just go and see what should be included, what should be prioritized, and what do different activities mean. And of course, MHPSS technical working groups that were already mentioned can use the MSP to see which activities are being implemented in a specific place. How complete is the humanitarian response in terms of these activities, and how can gaps be filled, and how also can we advocate to donors and others making decisions about resource allocation, governments, to direct them to what should be prioritized, where the gaps are, and how the gaps can be filled. Thank you.
Thank you so much. And actually, I really want to congratulate the regional organizations coming together to develop the MSP, WHO and UNHCR, UNICEF and UNFPA, because it has really made a difference right now in what you were saying. How do I do this? Now with so much interest to MHPSS, Berta. So really, really useful tool. Again, we have the link in the chat if you want to check, and you'll have also a QR code. But as you were saying, it's very easy, MHPSS, MSP, and it comes in Google. I think this complexity, all of those logos that we were saying, all of those sectors engaged in MHPSS is a reality in every humanitarian response. Not different in a refugee context, probably, Peter, but the focus that UNHCR has been placing on MHPSS throughout the years to make sure that in refugee context, we also have an adequate MHPSS response is quite considerable. So can you tell us what is that? What does that look like in a refugee context?
Thanks, Carmen. Yes, thanks for giving the opportunity to explain how UNHCR is doing it. Every agency works through their mandate and works with MHPSS. So UNICEF, IOM, UNFPA would have a slightly different story based on their mandate. For us, refugees are part of our mandate, so we have a strong emphasis on that. What I first want to say is MHPSS is not a sector for us, for all of us here. So it needs to be realized within existing sectors. That's the first thing. The second thing is that UNHCR works through partners. So you will not see a UNHCR clinic or a UNHCR psychosocial worker. We work through partners, and it could be international NGOs, but increasingly it's local NGOs, local actors, and governments. We try to integrate refugees within existing systems. And there is a bit of an issue, because MHPSS is usually not so strong in existing systems. So there we need to work with governments and see how we can strengthen their work. Those are the most important things. I may say a bit more later to give examples on how we do that in concrete contexts. But just to keep it simple for you, I would say I tell the people in the field we have to do 3 things. 1, make clinical mental health services available for everyone. If you have a severe mental health condition, you need to be able to see a doctor or a trained nurse to help you. So that's what we do. I will give explanations later. Secondly, it's not only medical, it should also be counseling, talking, case management. So that's the second part. Focused psychosocial support is, as we call it in our jargon. And lastly, and I should have said that first, but I always say it last, helping communities help themselves, building capacity within communities, within families. There are lots of strengths, but they don't always are enabled. So we see also MHPSS as an enabling mechanism to help people help themselves. I will say much more, but perhaps in the next question.
Thank you, Peter. Also, wearing my WHO hat, one of the pitfalls that I see sometimes from countries while looking at refugees' mental health is thinking of refugees only as a crisis. Sometimes the influx and the presence of refugees in one country is an opportunity to revisit the mental health and have a mental health reform in the country. Recently, there were so many examples. We heard the colleagues from Poland, and Poland is revising its mental health integration to primary health care now after the refugees influx from Ukraine. But the same happened in Iraq before, same happened in Turkey. Lebanon is having a full mental health reform after the Syrian influx. But to be able to do all that, you need human resources on the ground. And to make sure that you have rapidly available human resources in a field where the key issue we have is that we don't have enough people is a challenge. But that's why we had the Dutch support, an interagency mental health and psychosocial support rapid deployment mechanism that Sandra will tell us about.
Yes, thank you, Fahmi. Yes, after the Mind to Mind conference in 2019 in the Netherlands, it was also time for action. And one of the action points was actually setting up a MHPSS search program. And search stands for basically rapid expertise that is going to be in the field. In this case, in MHPSS, it's interagency. We have decided upon that because it was most important to establish more working groups in various countries. And as you can see, the results are there, so that's nice. Search is also short-term gap filling and to support the working group for a temporary set of time. It's there to strengthen the MHPSS system in countries in crisis situations. And it's also important to strengthen capacities locally as much as we can. Of course, we have a database with experts, and for me, it's also a call to action to ask people to sign up to the database because there's always need for more expertise. We've also been able to send people to the field quite rapidly. For example, in the Ukraine response, we had a couple of people in the field in a couple of weeks. So that was quite successful, I think. We've been active for 4 years now, and we've had 42 deployments so far in 37 countries, just some numbers to give you a bit of an idea. Yeah, as I said, it was always interagency, and one of the criteria for us is also that one of the agencies take the lead because we need people to be employed, to be deployed, embedded in one of the hosting agencies. I'll leave it there for the moment.
Thank you so much. And I think both Fahmi and I are agreeing very much on what a game changer having a search mechanism has been for the MHPSS field. We didn't have the capacity to deploy people. And one of the biggest issues that we face in carrying the conversation that we've been having up till now is a coordination capacity. So to have the capacity to deploy a colleague that can activate these technical working groups and bring people together and do the mappings is really it's making a big difference. So yeah, we'll also have the link to to the mechanism website and take a look. And if you know good MHPSS experts, ask them. I join my voice to Sandra's, ask them to sign up, because there's definitely a lot of work coming our way. So yeah, looking forward to hear more in a minute. And as you can see, there's broad engagement in the reference group. We have our colleagues from UN agencies. We have government agencies helping us in things like the search mechanism. But very, very important, the majority of the organizations are NGOs, of course. So we're very grateful that Victor is joining us. Victor, you belong to the MHPSS Collaborative, who's been with us from the beginning. It's hosted by Save the Children. And for us, it's very important to have the role that organizations that the collaborative do inside of the reference group. So if you could just share with us what is the collaborative does and what is for you that contribution to the reference group.
Thanks so much, Carmen. So great to have this conversation happening. The MHPSS Collaborative is a global hub for research, advocacy, innovation, and learning that's hosted by Save the Children Denmark, like Carmen already mentioned. And we connect key academic and humanitarian actors who work with children and families in fragile and humanitarian settings across 4 key thematic areas. The first is education and ECD, early childhood development. The second is across adolescents and youth, engagement, participation, and leadership. The third is the climate change and ecological crisis portfolio. And the last for us is imagining climate, imagining and existing challenges. We've been co-leading the thematic, the MHPSS thematic child and family thematic group since its inception in 2019 with UNICEF. And the key goal of this group is basically to support long-term sustainable system strengthening, enhanced coordination and quality MHPSS for children and families. And some of the work that we have done, I think, have been already profiled by Fami. We contributed to the development of the My Hero Is You books, both books, which have reached over 100-something translations, 145 if I'm being specific. And we also contributed to the development of the MHPSS Child and Family Resource Collection, which is hosted on mhpss.net, and I think you should check it out. So this resource collection hosts a number of resources and key materials that are necessary for people working with children and families in humanitarian and fragile settings, which are easy to access, readily translatable, and very much useful to contributing to their work. And the last on the list is, of course, the interagency standing guide, suicide prevention thematic guide, which we developed a case study for and also contributed to its development.
Victor, thank you so much. All the products you kindly mentioned, I don't think would have not seen the light without the support of the MHPSS Collaborative and all the NGOs and UN agencies and Red Cross and Red Crescent societies who contributed. I think it's a nice and unique model of collaboration and how it fit not only to develop normative products, but actually how to have impact on the field, on technical working groups and in services and countries. And I think now we can open the floor, colleagues, for any questions you have to us. Sure. Yeah.
No, I just wanted to maybe give the opportunity, because we've been talking so much about country level implementation, and I think it was a good opportunity to hear maybe from Peter some examples of how UNHCR is working at country level.
I think that makes sense.
Yeah. Some of the good examples. And I have more questions for the others.
Thank you. I'll still keep it brief. No, it's a bit of a complicated answer because it depends. That really is the reality. It depends on the context, like what are the needs in a specific setting. It depends on also the legal context. Can the refugees, in our case, use national services or not? If not, you have to think of something else, a parallel system, which we in general don't like, but there are many cases where we have to resort to that for reasons of legal status of refugees, but sometimes also for practical reasons. Refugees are often in very remote corners of countries when systems are not very strong. but also dependent on the partners we have. If we have WHO doing MHGAP trainings in a country, we will work with WHO. If in that part where we work it isn't, then maybe we will do it ourselves or we do it with the Ministry of Health. So it depends. So let me very briefly give two examples. One is Bangladesh, which is where you have 1 million Rohingya refugees who are flocked together. They're in camps. And there you really have a parallel system because refugees cannot access the national system. So there you see the humanitarian agencies actually taking over a lot of the governance. So there are about 60 agencies working together on MHPSS, each from their own sector. That needs to be coordinated. So there is a coordination group, leadership changes. Currently it's IOM and UNHCR together. The services are then integrated in the way that I described. So for example, UNHCR employs health agencies who provide healthcare. And we have clearly said 5 years ago, you cannot be our partner if you do not include a mental health component, if you do not employ a psychiatric nurse, which they don't have in Bangladesh, or a psychologist in your clinic. So that's what we do there. I can go into the details, but let me not do that because you want to open the discussion. We have context-specific tools, let me say it like that. So the choice of the psychotherapies we choose is based on what is most appropriate for that level. And in this case, we chose something that had been tested with Rohingya refugees. Another example is in Africa, is Uganda, where actually the refugees are not in camps. They are in integrated settlements. They can actually move around, they can get employment. So there we work in a different way. We work much stronger with governmental health clinics, and we work a lot with civil society within the country, providing services both for refugees and for hosts. I want to say 100 more things, but I don't think you'll be my friend anymore. So if you want to know more, come to me after the meeting.
Well, it's the networks and partnerships week, so let's network after the session.
Maybe one thing about coordination, that's what I wanted to say. There is strong coordination in Uganda as well, and it's entirely led by NGOs, national NGOs, and also with support of international NGOs and the government. Actually, the UN has a limited role, and we're very happy about that.
Actually, that actually brings me to another question that we wanted to ask to Sandra, related. That need for coordination is probably one of the strongest focus that we have in requests for research, like getting coordination support as a one of the main things that we've received as requests. But we also would accept all the types of requests. So maybe it would be good to hear what kind of search we're doing the most, what kind of experts are we being required to deploy, and yeah, what can be achieved, what can be reached through the DSS mechanism.
Yeah, so far we've focused upon the interagency coordination function, but also thanks to WHO and BHA funds, we're now also able to support some other functions. And we have, well, we call it a menu, but it's quite a seasonal, flexible menu, I suppose. Because what we have, it's just some ideas that we have put on a sheet, and it's basically to have some other positions filled temporarily to set them up or to strengthen the capacity that is there on, for example, situational analysis, assessments or mappings. It's very important to have a better idea of what you're actually coordinating. Then sometimes there are struggles with monitoring and evaluation, need for capacity building, and sometimes technical support. It might be on various topics that have been mentioned, like peace building, integration of disaster risk reduction, prevention of suicide, substance use, old age, but also, like Peter was mentioning, the support maybe on integration of MHPSS informal local services. That could also be an idea that I just thought of and is not on the sheet, but this is the seasonal thing about the sheet. Yeah. And to mention, and I forgot to mention it in my first first talk, is that it's very important for us. We're just facilitating this program, but we can't do it without the co-chairs, because Fami and Carmen are supporting us with coaching of these experts to know exactly what is going on in that area, in that specific context. We don't know that from The Hague, our office. That's too difficult. So it's good to have people in knowing what is going on there. So I wanted to also mention that. Thank you very much.
And I promise this is my last question. But Victor, I really like that you're here, because it gives me the opportunity to also highlight on things that we need to do more. And we don't do everything perfect and great. Definitely youth engagement is something that we need to look more. We have expertise through agencies like UNICEF and Save the Children and the Collaborative. But if you have to give us a piece on how do we go about it, about youth engagement, given your expertise in that area.
This is a very exciting question for me, because it's basically my job role and definition. And I love to approach this using like 5 key components. The first is, for me, structure. And when I say structure, it means a defined common approach to how we engage children and young people. And for this, we're actually conducting a research right now with some brilliant students from the Geneva Graduate Institute. Paul is here. And the faculty, and this research is looking at exploring existing frameworks for how we think about and envision youth leadership, and exactly how this definition of youth leadership integrates into MHPSS responses in humanitarian emergencies. We already have some key important things coming up from this research, which show that there's not a predefined way for us to define what youth leadership means. Is it that we want young people employed in organizations working on the ground, or are we thinking about it as youth-led organizational mobilization on the ground? So we're still obviously exploring different things. We're just done with the literature review, and we'll keep you all updated. And the expectation for this research is that we're going to come up with a final product that looks at exploring how we can better understand doing this effectively and doing it more efficiently. The second component for me is accountability. And obviously, with a defined common approach, we need to have a way for us to keep ourselves accountable to our commitment to engaging young people and children meaningfully. And for the same product that we're working on, the same research, we're looking at developing an accountability framework that will have organizations like ours and yourselves to think about how we can check ourselves. Are we doing this? Are we doing this well? Are we engaging young people the way that we're meant to? Are we doing it, based on an assumption of specialty? But of course, this is going to take time. It's something that we think needs time, and that leads me to my next component, which is coordination. I think from this group and the IASC in itself, we've seen the importance of coordination. And like Fami already mentioned, we have a huge need with very limited capacity. But obviously, to do this better, we need to have proper partnerships with people on the ground in context that we work. And these partnerships, of course, should include definitely youth-led movements and mobilizations, which we are hoping is something that is a conversation that we're going to have as a group as well, to think about how we can have youth as a cross-cutting theme across all of the different thematic groups. The fourth is community. And for me, this is basically acknowledging that young people are the best place to reach other young people, those within their own generation, those in newer generations, and they're the ones that are the bridges to reach out to those that are not easily accessible or those that usually fall through the cracks. And for this, we're actually developing a platform that we call the Why Participate Network. And this network is going to be an opportunity for young people to connect with opportunities to engage and participate, to connect with the peers, learn from each other. For young people like myself, I still consider myself young, to deal with I would say the depression of transition. When you're older than 30, people no longer reach out to you to join panels and contribute to things because you're not the typical definition of the UN youth. But that's something that we know that we have dealt with. There's so many young people coming to say, hey, this is quite difficult for me. I don't feel as acknowledged as I used to. And the last is capacity. So capacity strengthening, capacity sharing, capacity building. And for this, we're actually working with a couple of colleagues at SAVE and SAVE in UK and Denmark to pilot a fellowship that looks more like a launch pad for entry-level work. We've talked about capacity and the lack of capacity within the sector, and this is probably what I'm going to be reaching out to Sandra after this event on, is how can we have young people involved and develop their capacity to actually be employed? You know, what is the entry level? What does that look like? So the fellowship would take them through different competencies for MHPSS, take them through the different ways that they can create programs and evaluate them and disseminate, you know, the whole components of it, and then give them an opportunity to actually be in organizations in their home countries. Because from our research, we found that most times the current fellowships and the current models of fellowships they have young people leaving their communities in their own countries and going to the West, and they learn from contexts that are not necessarily similar to the context they come from. And that's, to me, like it betrays the idea of what we're trying to build. So these are some of the things that we're currently doing and we'll be doing, and obviously we'll keep the group updated on them.
Thank you so much. And thank you so much, colleagues. I'm already seeing very interesting questions that I'm kind of glad that I don't have to answer myself. I'm going to throw to the panelists because they're not easy questions in the audience online. Maybe I would like to check first with the room if there's any questions. Yeah, we have 1, 2, 3. So if it's okay, I'll do one room, one online, and then we go like that. Sounds good? So maybe our colleague on the top floor.
Thank you. Sorry for sitting so far away. Thank you so much. This has been so interesting to get such a good overview of this really important work. My name is Emily. I'm the Humanitarian Programs Manager with Internews. So we work on supporting healthy information ecosystems, and we work a lot with the accountability to affected populations groups, community engagement and accountability, risk communications, all that sort of stuff. I'm really interested in the connections between mental health and psychosocial support and the need for access to good information and trusted information, not just about mental health and psychosocial support, but about services in general and the way that interacts and can impact, of course, the psychosocial health of a person and a community. I think, yeah, particularly in relation to this idea of trusted sources and not just receiving information, but being able to give feedback and participate in decision making. Yeah, and how that kind of interacts. I know that there's, I'm sure, connections within IFRC, between the psychosocial center and the CEA team, but I feel like in listening to this presentation that where perhaps at least our organization is amiss in not engaging with this more. So I'd love to hear if there is any interaction at the sort of technical working group or the reference group level with the accountability and community engagement kind of work. Thank you. I don't know if Inka.
Because there is an action sheet in minimum service package specifically about that. I think that would be a good question for Inka.
Yeah, thank you. So from the MSP perspective, there are 2 MSP activities that are relevant to this one. One is in section 2. Section 2 of the MSP are basically things that you have to do regardless of which program you implement. So it's design and coordinate programs, develop and implement M&D, staff care, and staff competencies are the things you always need. So part of design and plan is exactly that, and coordinate is figuring out who does what already, also through the MHPSS technical working group, and seeing who provides which services and supports, and then developing referral pathways and links so that different organizations and agencies can link with one another. And if they come across somebody who has a specific need, they can link them with another service provider or another support. And that's really critical, given that many people who experience mental health problems often have other needs, have protection needs, have GBV issues, have employment needs, have many different things that we need to also connect them to. So I think that is critical. The coordination group or the MHPSS technical working group, of course, functions as kind of a group to enable that kind of coordination and linking, and sometimes they also take on mapping of different service providers in a specific region, and then developing, for example, service directories to link different groups. I think there was another point about also accountability and feedback, which I think is more part of the also monitoring and evaluation. And also, I should say, meal, even because it does it also includes accountability and learning. And that is also a central part, given that it's in section 2, it means it needs to be part of every program. So to actually not just evaluate at the end, but monitor throughout and get feedback as well on how people are perceiving services and support, how accessible they are. Also, we have a section on at-risk groups and having an analysis of at-risk groups in every humanitarian settings, because these at-risk groups are always different. We cannot assume a group is at risk or not at risk. So we always have to make a contextual analysis on that and make sure that these groups can access the activities as well. Sorry, that was kind of long, but.
To complement also what Inke mentioned, what we have in the minimum service package, but also what we see operationally sometimes is that lack of information when we do our regular humanitarian work can itself be a source of anxiety. I have seen in some camps or in some of the displaced population, including in urban setting, not knowing where to go to access healthcare, not knowing where to go to receive the cash or to receive the food distribution, or knowing about whether it exists or not, although it sometimes might do exist. But the lack of information distribution actually might induce an anxiety. There is a misconception that our field is only about managing trauma or about clinical intervention or about treating people. Our field is also about mental health and psychosocial approach, which include good information sharing, which have an impact on mental health and psychosocial well-being, as many other aspects in humanitarian work.
I 100% agree. Thank you so much, colleagues. Is that a good answer to you? Brilliant. We have a very provocative, I think, question in the chat from a colleague from my organization, from the Red Cross. It says MHPSS crosscuts all sectors of IFRC work, yet is still not embraced in reality. So it is supposed to be cross-cutting, but it's not yet in reality embraced by all of the different sectors. Could MHPSS get more traction as a standalone sector, which is a conversation that we've had, I think, quite often. So I don't know if maybe Peter, would you like to, because we had a little conversation about this on our last big meeting.
Yeah, but I don't have the answer. The thing is that there's a conscious decision in 2007 to have not an extra sector or cluster, but to have MHPSS integrated for practical reasons, political reasons, but also for content reasons. I think it's just better if you do not just rely on the small number of specialists, and it will never be enough. So I am a strong advocate for multi-sectoral approaches to MHPSS, but I didn't hear from which organization the person was, and that's perhaps also good. Could be mine, could be yours, could be anyone, because this is an issue that we deal with. How can you drive change without, let's say, the power of being a sector which is in your organogram? And that is a dilemma. And my answer would be, you need champions. You need champions. So I do not say that if MHPSS is not a sector, that you don't need MHPSS specialists. You need them, but their role is not to do it all themselves, but is to help people in the sectors to do it. So I would say you need them as catalysts. You need them. I see, frankly, in the countries where UNHCR has an MHPSS officer, we don't have that in all countries, things go much better because you have a person takes control, gives the training here, gives support there. It helps a lot. So I think we need more dedicated attention for MHPSS, including in human resources. I would stop short of making it a sector, but that's a political decision. I wouldn't be totally against it. Sometimes I wish we would be, but
I remember it was many years back actually. Now it's at the Libyan Egyptian borders with the big exodus, with many refugees coming out of Libya with the start of the 2011 revolution. I found one of the organizations having a tent, and I found a colleague with totally no clients, no beneficiaries coming to that tent, and that tent was providing mental health with a big label, mental health and psychosocial support for people affected by gender-based violence. Nobody was coming because of the stigma, because that's a clear example of a non-integrated service. There is a risk if we go and have our own sector. For example, imagine the health cluster procuring essential medication, and they say, out of all this, because mental health is a sector, we are not going to procure mental health medication. Go and do it. Imagine if protection clusters say we are going to protect all the vulnerable population, but people in facilities for people with psychosocial, intellectual, and cognitive disabilities, we are not going to do protection for this group. There is a risk if we are a separate sector that we lose the accountability that exists for this area and this group of population within every sector and cluster.
Very much agree. Just looking at time and wanted to get as many questions as possible. We had a colleague in the yes, it was yes, right in front of me with a laptop.
Hi, thanks. I'm Anne Hart, head of ELRA's Research for Health and Humanitarian Crises program. And we've had the privilege of working with the reference group on a recent research priority setting exercise, for which I thank you for your support. In addition to that, we've funded around 25 rigorous research studies, testing and evaluating the effectiveness of MHPSS interventions in humanitarian settings, including adapting some of them for particular contexts or population groups. Now, one of the things that we also try to do is to make sure that this new evidence and these new interventions are actually taken up by and used by operational partners, MHPSS partners working on the ground. And my question is really, how can we work better with the reference group to enable these new interventions and this new evidence to actually really inform the practices that are being used by people on the ground? Thank you.
Thank you so much. And first of all, apologies. We've seen each other so many times on the screen that is like, I don't recognize you face to face. Thank you so much for that question. Very, very relevant. Who would I? Okay. I think this is a very important question. And there is it's not coincidence that we work together in that important prioritization of MHPSS research piece, because we are from the inception, as we were saying before, we are very much caring of the quality, of keeping the quality. And a big part of keeping that quality is, of course, having evidence-based and research-informed work. The problem is how we carry it down. I think for us, one of the most important ways is, again, through the technical working groups, to making sure that they are aware of these priorities, but also advocating a bit more for that research work at country level, that collaborative work with not only NGOs or civil society organizations at country level, but also research institutions at country level. I think that is something that our technical working groups in some countries are doing. They actually have members of academia as members as part of the technical working group, but it's not very common. So I think that is a big part that we should definitely continue to promote. And then I will go to the, if you like, other side of the spectrum, and I would also talk very strongly about donor engagement, because in the end, what gets funded to be implemented also needs to be very strongly informed by what we get from research. So we can do wonderful research on what works, what doesn't work, but if we keep on then maybe funding projects, or NGOs keep on doing projects that maybe are not aligned with those research. So I think for me, the work that we can do in disseminating donor level, agency level, and country level through the technical working groups, I think this is a key part. I think for those who might not be familiar, we have two pieces now. Twice we've done a research looking at what needs to be researched the most on MHPSS. Now that we have that list, can we go to academic institutions? Can we go to organizations working on MHPSS and I would have a very strong call for what a dear colleague of mine calls for all of us to become a bit academics. I really like this term that she always used, which is for those practitioners on the ground to understand better what is the role of research in our work, and for researchers to understand better what is the role of MHPSS organizations on the ground, because I think we still need to combine better and understand each other's role much better. Peter, I can see you want to.
If I can.
Please, go ahead.
Again, I'll do it brief. No, this R2H, if you don't know it, it's really great. It is transformative for the field, the kind of researches that are being done. And I'm involved in several of them. And sometimes you do see that there is a disconnect between the uptake, the research itself and how it's taken up. And I just want to say two things that I think are key. And one is continuous stakeholder engagement, which is the NGOs, the government, but also the communities themselves. And I think R2HC is quite strong in pushing the researchers who may not think of that as their core activity to do that from the beginning. So keep people engaged. And secondly is time. It just uptake takes time, and we need to be realistic. You cannot do an RCT in 2 years and then expect that everyone will start funding it massively. So that brings me to my second point then. I think we also need different kind of research, which is implementation research and research about how to scale up, what we can learn from that. And that needs partnerships probably between funders who fund the activity itself and researchers who research how it can best be taken up in routine care. But I do see it going sometimes very well, but also sometimes that actually a lot of efforts have been done to research and intervention, and the research is done and nobody takes it up. So it must be factored in.
Did you want to add something on that?
I think you and Peter covered the question from our colleagues at R2HC very well, and we are grateful for your support in identifying the research priorities. But I actually want to invite my colleague Maya to give us a quick overview. Maya, can you share with the colleagues, what do we do when we want to disseminate a product? You played a critical role in disseminating this successful product that flies. What do we do when we have a product as a reference group to disseminate it?
Thank you, Fahmi. So when we have a product like the children's book, My Hero Is You, we release it and share it through all our communication channels. And then both member agencies or partner agencies can reach out to us, for example, to ask whether they can translate the resource or how they can actually implement and use it in their programs and activities. We also receive a lot of information from technical working groups at country level that they use the resources to adapt and contextualize to their needs. Is that what you're looking for in the, yeah?
This is what makes the reference group well positioned to act as a knowledge translation platform, because we are not a global structure only. We are linked to country level implementation. And as Maya kindly shared, when there is a product released, that's what make a product translated to 100+ languages. Because there are country implementers who are looking for these products to standardize their practice. So immediately the knowledge translation, once a product is released from the IASC, which have a credibility as a logo, to be translated and used at country level. Thank you, Maya.
I'm having a difficult moment with so many questions and trying to decide how. I'm going to answer myself one very quick one, which is how to get in contact with the technical working groups in country level. That is through the reference group. So we'll put maybe is Maya one of the QRs at the end us? I think so. So for those in the room, the QR code. For those in the chat, I just put the email address of the reference group. So basically we just connect people and make that happen. And then there's one specific question for refugees. I'm going to find it. Can you share if there's any specific challenges that practitioners face working with refugees on MHPSS, especially different religious groups? Which religion groups more welcome to MHPSS support? That's an interesting question. A stigma around MHPSS, and if so, if you have any tips around a stigma.
I didn't get
If there's
the question.
challenges, specific challenges working on MHPSS with refugees, then an interesting turn of the question is if you find that this difference working with different religious groups in MHPSS and tips around stigma and MHPSS.
Yeah. So refugees have, let's say, first of all, refugees are people. So with their cultural background, their own history. So that's the first thing. So they're like other people. However, the challenges refugees face are sometimes more because of because of the displacement, but also because of the situation in the hosting country. So you see all kinds of differences between in access of services, in appropriateness of services, in adaptability of services, whether there are people available who speak the language that you are familiar in. So there are definitely challenges. There are definitely challenges. So that's what I would leave it at that. When it comes to religious and cultural factors, they play a role in help-seeking behavior and in how you frame the issue. That's not specific for refugees, and I would not necessarily immediately consider it a challenge or a problem that we need to surmount. It's just a reality. People think different than a mental health professional, and that's sometimes very good, actually. But we need to link. So that means we need to, if you do MHPSS programs, you need to adapt it to the language and the examples and the settings that people feel comfortable with. And that's what I would say. And I would say try always to use, let's say, the people you work with, try to use their strengths. So when it comes to religion, there are good examples of working with pastors, with imams, with religious leaders. And there are also examples where it is complicated. But you need to look for allies. And that is not different for religious groups than it is for other let's say, sectors in society.
Brilliant. We're going to take the last one from the room. I think we have time. We have 3 minutes. And then I'll read very quickly, it's like one word from each of the questions in the chat and kind of refer like very quickly. But maybe the final question from the room. Is that okay? Come to talk to us afterwards.
I can be quick if we can squeeze in two if you want. My name's Lauren Phillips. I work with the UN Volunteers Program, and we've had the pleasure of collaborating with a few other entities on stage here before when it comes to this agenda. So firstly, massive congratulations to you all for pushing this forward. It's so essential and so often too overlooked. We had a recent experience, it was with the Turkey and Syria earthquake response of collaborating with OCHA and UNICEF. In a really short period of time, so we're talking 6 hours, deploy online volunteers to support and supplement the counselling services. And it was really looking at kind of addressing the gaps that were kind of identified earlier that, you know, what if it's not possible for certain groups to be integrated into national systems, if the national systems are overwhelmed, if they're already very fragile, you know, what are the ways of kind of supplementing that support? So they were supporting either on translating, you know, the existing materials that you already have and the tools that these organizations already had, or disseminating them to certain communities like online. And so just wondering, just for some reflections from the panel in terms of the applicability or, you know, the potential for that kind of model of collaboration a little bit more. Of course, very short term. And of course, it's, you know, you've got to think systems to think bigger, but just in terms of that critical window in those first kind of 48, 72 hours of getting that information out there. So interested in the panel's views on that kind of remote, you know, whether it's volunteering or otherwise support. Thank you.
Any takes? Yes, go ahead.
I think it fits very much into the reality of what young people, you know, they're mostly online, they're already connected. So it's kind of easier for them to actually jump on initiatives like this. You know, the Syria-Turkey crisis is an example of how much, you know, they raised money in very short time, so much money, and they moved it very quickly to those in need. So I think it's very practical. And it's something that maybe we should set up a much more coordinated approach to engaging, like some guidelines to doing so. In your experience, my experience actually providing and facilitating online support to young people within crisis settings is the fact that even the ones providing it in country actually themselves are also experiencing the stress. So it's also been very intentional and practical about making sure they're connected to help and support as they need it.
Brilliant. I can't believe an hour and a half passed so quickly. I'm just going to make 2 comments on the rest of the questions. There's one question about contextualization, which is very, very important. And of course, that preparation that the minimum service package talks about before anything, it also includes contextualization of all of the resources that are created by different organizations globally. So the answer will be yes, very much through the technical working groups. It can be that collaboration of agencies at country level to first take the tool, contextualize it, and then use it. The other one is around disabilities. And yes, indeed, there is a lot of work that there's organizations that have high expertise on MHPSS for persons with disabilities, CBM, humanity and inclusion. But also from the reference group, we are also about to publish probably very soon also a guidelines for MHPSS professionals to do more and better work in disability inclusion. So stay tuned for those in that central QR code. Colleagues, I'm so grateful to all of you for joining us today. Thank you so much. And thank you so much for the audience. I think it was really engaging, which we could have done 45 minutes of questions probably. Thank you so much. We'll be around for the rest of the day and the rest of the Humanitarian Networks and Partnership Week. So come talk to us and keep on engaging with MHPSS because it's an area that needs all of us to be engaged with. Ami, over to you for final.
Thanks, Carmen. Thanks everyone for participating, and we hope we conveyed the message what's happening in mental health and psychosocial support, and how can you engage with all of us. Thanks everyone.
Thank you.